Welcome to Discover Health, a White Mountain perspective. I am your host, Dr. Tom Barela, and I would say welcome today. We have a very interesting program today, a program about pain. Pain is a problem that all of us will experience at some time of our life. The question is how severe the pain will be and how long it will last. And today we have a very special guest, Dr. Dax Trujillo, the pain management specialist from Summit Healthcare. And I would say welcome, Dr. Trujillo.
Well, thank you so much for having me.
Well, I appreciate you being here. And you are the only full-time pain management person here on the mountain that's a physician?
Yeah, to my knowledge.
To your knowledge, and my knowledge too. And a very needed specialty up here, since pain seems to be a universal problem for people and a highly ubiquitous problem. So I guess I would start the conversation today by asking the simple question. From a pain specialist standpoint, how do you view pain?
Well, it's an interesting question. I don't necessarily view pain because it's such a subjective experience for most patients. Certainly we measure that and we monitor it, and when we treat patients we try to see what progress we're making in regards to their pain scale. But as you've experienced, I'm sure there's some days you're having a good day and maybe your pain's not so bad, or even the pain that you would normally have doesn't bother you so much because things are going well. And then other days you're having a bad day and the littlest thing is just that much more aggravating. And so I look at more from a functionality perspective. If someone's back pain or neck pain or knee pain or hip pain or shoulder pain is impacting their ability to participate in activities they'd like to do, family, friends, taking care of the home, that's when I feel like pain has become pathologic and is negatively impacting their lives.
So pain is really more than that personalized feeling. It really, you view it kind of like how it impacts what you do.
Yeah, certainly pain is a totally individual experience. If you, for instance, go to your cardiologist and you're having chest pain, and the cardiologist does a myriad of tests and determines whatever the problem might be with your heart, they can address that issue, and you can go back to the cardiologist and you might still have chest pain or some aspect of your cardiac function that's impacting your functionality. And they can repeat the test and they can quantify exactly how much they've improved the particular issue, whether it be the ejection fraction or the flow through the stent or whatever it might be. We don't have any tests like that in pain. And so the patient is a gold standard, and they tell us, I feel like this has been an effective treatment for it, or I don't feel like it's been an effective treatment. So the way we approach pain is unique. There's no blood tests, there's no echocardiogram, there's no you can't put someone in an MRI scanner and tell them how much pain they have. You have to take their experience, their collective experience, and try to adjust your treatment to improve that.
And so when most of the people that come to see you are referred, I suspect?
Yeah, in the current environment with insurances and whatnot, typically we require a referral from the primary care physician to get the process started to come see us. It certainly could come from a spine surgeon or someone who's seen you otherwise and wants you to be evaluated by us. But difficult to get someone authorized for their insurance from like a walk-in perspective.
I understand, and I guess that makes sense. So most of the people that come to you already have a diagnosis for the cause of their pain?
I don't necessarily require that. I'll see someone for back pain, and there could be a myriad of reasons for them having back pain. A lot of what we do when we first see a patient and assess them is help them to understand what's causing their back pain, because, for instance, you could have degenerative disc disease in your back, and that could be causing that shooting electric pins and needle type pain that classically people describe as sciatica. Or they could have some arthritis in their back, and that's more like a throbby, achy band in their back. And you can have both, and people collectively contribute that to back pain. And the treatments for the two different problems are distinct, and they don't cross over. And so sometimes what I do is prepare patients for the fact that there might be multiple things that are causing pain in their back and how we'll approach each of those issues. So I often tell patients it's kind of like drinking from a fire hydrant the first time they come in. It's a lot of information, I try to repeat it as often as I can on subsequent visits because it's a lot to take in. And to be fair, I think our primary care colleagues, the specifics of that's really not, they're not going to be doing the injections or the surgeries that are designed to treat those. And so for them to, obviously most of them are very capable of saying, hey, this is degenerative disc disease versus spondylotic pain and make that distinction. But for them, I think identifying that there's, anatomic pathology for the patient in the back or the neck for that matter, shoulder, knee, hip, wherever it might be, and then sending them to us, I feel like that's where we pick up the ball. So I'm more than happy to institute physical therapy, imaging, whatever other diagnostic studies that may be required. Traditionally, though, they came with, I want the shot here for this. And those days are kind of gone in pain medicine.
Is that right?
Yeah, it used to, a lot of what pain doctors used to do in the past were driven by the spine surgeons. Because, 10, 20 years ago, you didn't go to a pain doctor, it was barely a specialty. And so you got sent to the spine surgeon, then the spine surgeon decided, well, I'm going to send you to the pain guy first because maybe I don't want to operate just yet, or maybe I think there's some inflammation, I want some steroid injections, or maybe I want to buy some time, it's a young patient. And they would subsequently send them to the pain doctors with very specific directions, hey, I want the shot here or there. And over time, because of the regulatory concerns and the myriad of medical options and things like spinal cord stimulation and intrathecal targeted drug delivery systems, pain's really grown into a specialty where I view us as more the cardiologist to the cardiac surgeon, as in we see patients, we screen them, and then we decide if they should go to surgery, as opposed to them coming from the surgeon. But those historical routes are still pretty well instaunched.
Well, as we were talking before we started, one of your descriptors is in having to understand pain is to recognize that pain is protective.
Yeah, absolutely. So we discussed there's people who are congenitally insensate to pain, and they, they can't appreciate if they step on a nail or they touch a hot pan, and subsequently they have short lifespans. And so pain itself is protective. And so that to me leads back to the whole concept of looking at functionality. It's fantastic if someone comes in, we provide them with an intervention and they go from a 10 to a 0. That's great for them, and quite frankly, it makes me look good. But I'm much more interested that they're out doing the things they want to do, even if their pain score is still, say it went from an 8 to a 6, but they're active. That's what's important.
Wow. And so when people come to you, how do you decide on an approach to pain, their pain management? Is it all disease related? I mean, for most of the people that end up at a pain specialist, from your description, it sounds like a lot of times the primary care physician or referring physician has tried the more conservative treatments, maybe physical therapy, maybe ibuprofen type medications, non-steroidal anti-inflammatories, or whatever. And that actually brings up another question. How often do you see patients that have tried complementary medicine before they get to you?
Well, to answer the first question, typically it is disease-based. So we do a comprehensive evaluation, physical exam, review all the imaging that's available, and if we feel like the diagnostic studies aren't adequate, we'll subsequently order those. Like you said, usually people have had the opportunity to go to physical therapy or try more conservative medical measures, but if they haven't, certainly we institute those at that time. But it's very specific to the process. We try to take the whole patient into consideration. Some patients are very concerned about having injections, let's say, and they want more of a medically based approach. Well, we're happy to tailor that to them. Some people are very phobic of the medications, and so they're more interested in interventional treatments, and so we tailor that to them. I think the reality of all those options, while needing to be specifically tailored to the disease itself, is, the more arrows you have in your quiver, the more opportunities you have to fight the pain. And so I like to have a myriad of approaches, because as you add each adjuvant, that should help control the pain. And I think that dovetails into your next point. If someone comes to me and says they're using inversion therapy or chiropractics or acupuncture or any of those therapies. With very few exceptions, I encourage patients to consider them. In fact, I solicit patients' feedback on whom they see and what they get done, just so that I can keep people in the area abreast of options for them to consider if that's something they would like to try.
Yeah, we actually on this program we've interviewed one lady who's hypnosis therapy, and in terms of the treatment of pain, with variable outcomes like any
anything with back pain.
Yeah, and so I would say since you do injections, that must mean, at least to the casual observer, that much of what you deal with has been back pain.
Yeah, I mean, when you're a hammer, the world's a nail, and so the vast majority of what I do is back and neck pain. That's not to say we don't deal with, atypical pain syndromes like complex regional pain syndrome or cancer pain. Those are things that we can certainly offer services for. But as we spoke about earlier, back pain's probably a universal experience at some point. Whether you seek out treatment or not is up to the individual. But it's got an incredibly high incidence, and it's the back and neck pain are where we do the majority of our work.
And you were also mentioning earlier about the population aging as one of the reasons why you end up being so busy.
Yeah. We mentioned the World Health Organization recently came out with a study where, worldwide, back pain was the third leading cause of disability. And this isn't something that just represents the United States, it represents other countries. In fact, some of the highest disability countries in the world were like Germany and France, where they have an aging population. And one of the funny parts about the article was very population-based, and they put in a little quip in there. Turns out as you get older, your back tends to hurt. And I thought it was funny that the author included that in this very technical, statistically based write-up of the issue. So, I mean, it makes sense. It's a common universal experience.
So, the main cause, let's just focus on back pain for a second here. Are there different types of back pain?
Absolutely. So, the first slide we have just kind of talks about a general broad stroke of things that we offer to patients.
Okay.
We can do, and I'll launch into some of these more specifically, but the point of the first slide, when we talk about epidural steroid injections, radiofrequency ablation, physical therapy, spinal cord stimulation, intrathecal pain pumps, joint injections, nerve blocks, trigger point injections, and then medical management, is to kind of bring back and talk about that we try to take this holistic approach to the patient, try to custom the treatment to them, customize the treatment to the patient themselves, and again provide as many arrows in the quiver.
Okay, that's exactly the analogy I thought you were driving at.
But if we look at the second slide and we move forward to, second slide, degenerative disc disease. This is really where the disease starts. The first process and listen, the name degenerative is really apropos because this is a disease that continues over time. And I often feel like I'm the bad guy delivering news all the time. People ask me, well, am I going to have to deal with this for the rest of my life? And like hypertension or like diabetes, yeah, you may have to. And likely it's going to continue to get worse. And what happens is the disc itself, and the analogy I use is a lot like a tire with air in it. So as that tire starts to lose air, you start to ride on the rims and it puts more strain on the system. And that tire can bulge out and push against the nerve. And that tends to cause that classic burning, shooting, electric pins and needle, sciatic type pain. And when patients come in with degenerative disc disease as their primary issue, because it's inflammatory by mouth, well, that's great. The same number of molecules go to your nose, go to your elbow, as go to your back. Or I can put 100% of that medicine directly on the area that's inflamed and try and control it. So it may or may not have benefit. My ability to predict whether that's going to be beneficial for someone is very low. It's also difficult for me to predict the duration. But for those patients that it does work for, it's a sustainable therapy over time. The biggest problem we have, or not the biggest problem we have, the most common problem we have is that it combines with other disease processes. So as you're riding on that flat tire from the deflated disc, the joints in the back of the spine start to develop extra strain. And you can develop arthritis in your back. And, that's the other issue. And that tends to be the throbby, and I've got another slide for it there. Spondylosis being the medical description of that, but it's just arthritis in your back like you get in your shoulder, your knee, your hip. And because of that additional wear and tear on those joints, you get that throbby, achy band of pain. And that's going back to when we were first talking. That's what I have to tease that out for patients. I have to tell them, hey, you have back pain generically, but you have two different problems. And unlike the steroid injection where I put the steroid on the disc, here I like to use radiofrequency ablation to denervate the joint so that the pain goes away. It's a much more sustainable therapy.
Denervate.
Denervate, yeah. So if someone comes in with lumbar spondylosis, I do a series of test injections to make sure that that's the punitive pain source in regards to their arthritic pain. And if it is, I place a radiofrequency electrode on the nerve. I put energy through that electrode, create heat, and it denervates the nerve. 85% of patients are 80% improved for 10.5 months with that therapy. So it's a great sustainable therapy. And it's something that we can predict the outcome from pretty reliably. But we do need to do the test and injections to make sure we're in the right spot.
If you de-innervate that, I'm just thinking, how can you tell if there's significant progression of the disease itself?
Yeah, that's a common question. People are very concerned,
Okay.
like, if I don't have a nerve back here, am I going to hurt myself? And yet the answer is, well, if you're going to go throw boulders over your head or tow a semi with a rope like a strongman competition, you're probably going to hurt your back. But most of the lateral stabilizing nerves that go through stretch receptors and the ligamentous aspects of the spine are still intact. This is a nerve that goes directly in the joint itself, and it only senses pain in the joint. So all the stabilizing elements of your spine are still intact. So you're not going to follow through on your golf swing and do a 360 maneuver and do something funny to your back. That's not how it works. But it does take that intra-articular pain away from the joint in a pretty reliable fashion. So people have increased range of motion, increased mobility. Now, to your question, is your back going to continue to get worse? Unfortunately, yes. But that is part and parcel of the disease, and that's the difficult part. I want to maintain function for as long as I can. I can't stop the progression of the disease.
And that's your basic issue that you talked about earlier, is that function is the primary thing. Now, a lot of orthopedic type people that initially see people with lower back pain prescribe physical therapy as the initial treatment. Can you really stabilize the back with physical therapy enough to prevent progression of degeneration?
Well, I mean, it's certainly not going to hurt. It's, the analogy I like to use with my patients is, if you don't want your disease to progress, I can put you in bubble wrap and we can lay you on the couch and your back's not going to get any worse. But that's bad for your heart, it's bad for your soul, it's bad for all these things, right?
Bad for your weight too, because you're sitting around eating all the time.
Cholesterol levels, yeah, you're not gonna do well. So this is a balancing act. Yeah, if you're gonna actively participate in physical therapy and increase your core strength, your range of motion, and your stabilizers of the spine, you're gonna improve the stability of the area. You're gonna increase your range of motion, and you're gonna get out and you're gonna do stuff, and that's really what's critical. Is it gonna continue to wear and tear on your back? Yeah. I mean, I'm a big fan of aquatherapy, where it reduces the load, but you're still getting a lot of the core work. And to me, that's the best balance of both things.
And what is aquatherapy?
So that's where you do your physical therapy in the water, and so you're taking the additional gravitational strain off the knees and the hips and the back itself. So just walking through water is incredibly therapeutic for your back, because you're rotating, you're using a lot of core musculature, you've got the resistance of the water itself to your motion, but you have offloaded a lot of the things that continue to progress the disease, like your own body weight.
And again, the thought process with that is, if you strengthen your muscles, you stabilize your back.
Stabilize the joints, absolutely.
Stabilize the joints.
Core stabilization is a key. Everything builds off your core. So you can't do anything if you don't have a strong core.
Okay, and that is a fundamental of physical therapy, is all
absolutely
what you can do to raise your core muscles.
Absolutely.
All right. And you talk here about spinal cord stimulation?
Yeah. One therapy that we can offer to patients who've sort of been through the mill, so to speak. They've had maybe back surgery. Maybe they've had multiple back surgeries. Maybe they've tried the injections and they didn't work. Maybe they've had the nerve burn, and it worked once or twice or 3 or 5 times, but eventually they ended up going to surgery. And medications, or maybe there's side effect issues with the medications, maybe they've taken a lot of medications and they don't want to continue to take a lot of medications. This is a therapy that we can do for patients that can provide them with just another arrow in that quiver to fight their pain. And what it involves is, the beauty of this therapy is it's like test driving a car. So you put in the stimulator temporarily and you take it home for a few days and you try it. And I ask patients to do all the things at home that they want to be able to do. If you want to be able to go, you're a small motor mechanic and you want to be able to go sit on a bench in your garage and be able to sit there for a long time period and work on that small motor, you go out and do that while you have your stimulator in, and you see if it helps you be able to do that.
Okay.
If you have dogs and you're an avid dog walker, you go out and walk the dogs and you see what happens. If it helps,
on it, it's back to function.
Yeah, it's back to function.
It's back to function. You know, I see on your list here you have trigger point injections.
Yeah.
This was really popular 30 years ago.
Yeah.
Maybe 40 years ago when I started in medicine. Is that still a popular?
I don't think it's as in vogue as it used to be. It's nice to have a backup plan, or a plan for patients that the more. So here's what I fundamentally believe. I believe in the bear story. So you're running from a bear, and the bear's about to get you. So you're not looking where you're going. You're looking back. That bear's right there, and you're not looking. So you run off a cliff. Well, good news. The bear didn't eat you.
Yeah, bear didn't eat you.
Bad news, you've fallen down that cliff, and let's say you've broken your leg. Well, if you were at the hospital, we'd take you back and we'd fix that fracture and we'd stabilize it and we'd help it heal. But in nature, what happens is that damaged tissue is going to send a signal out to the muscles are going to go into spasm, and they're going to splint that injury. Well, these people clearly have damaged backs. They have arthritis, they have degenerative disc disease. So their back muscles are constantly trying to splint these damaged areas. It's like standing on your tiptoes all day long. So they get tons of myofascial pain. In fact, 80% of back pain is myofascial in nature. So for them to get some respite from a trigger point injection, I think is actually a pretty viable therapy.
Wow, I'm impressed. And we're getting close to time. It's gone really quickly and surprisingly so. The last thing on your list, I know this is medication management and oral medication. Narcotics?
Yeah, I mean, we've kind of broached on this issue, and I'm always happy to hear people's perspectives on it. You know, as we well know right now, there's great concern about ongoing narcotic management of pain. Not just to say narcotics, we use all sorts of medications, as you mentioned, NSAIDs or membrane stabilizers like gabapentin, Lyrica, Neurontin. Those all have their place depending on the type of pain generated. SSRIs, et cetera, et cetera. But I think narcotics are very important right now because of the regulatory and legislative environment. I think that, it's another arrow in your quiver. Why take a tool out of your hand if you can't use it? And the analogy I would use is gun control. Some people would argue if there weren't any guns, no one would get accidentally hurt by a weapon. And I think in this community, I think they're very understanding about the concept of, hey, there's a lot of responsible users of firearms. And so I don't diminish the concerns from an epidemiologic standpoint with medical management of pain, but I see a lot of patients that are older. They have pretty severe disease. They've failed multiple interventional therapies. The surgeon can't operate on them anymore because they have a bad heart, or they're on blood thinners because they've had cardiac issues, or whatever the issue might be, bad kidneys, bad lungs, whatever it might be. And so for them to hear there's no option, and most of them are pretty reticent to take pain medicines, but if it gives them some respite, I think it's reasonable. And my own personal experience is my grandma had horrible spinal disease, and her primary care was understandably concerned about giving her too many pain pills, and for good reason. Any patient that launches on narcotic management, I go through the list of things that aren't good about it first, because I want them to be prepared for those issues. There definitely are drawbacks. But she would agonize every day over whether she should split her pill in half and not get complete relief, but have the opportunity to take half a pill later, or take her whole pill and get some relief and know it was going to wear off. And that was a decision for her every day until she died. And I really felt like that's something I didn't think was right. And so it's something I I try to balance in my practice. I try to ensure that people have access to that option if it's one of the few options they do have.
And it's an interesting story, because in truth, many people wait when they're properly managed for pain management. Many people wait till they're in pain to take their pain medicine, instead of recognizing that the proper way to take it is the right dose periodically, so that you don't feel the pain and your function is adequate. So we're almost out, but I have one question that we did not talk about in preparation for this. Is the new modality for pain management has been marijuana.
Oh.
I mean, that's essentially what you have as a background in order to get approved, for at least in Arizona, for that. Is it a significant piece of, I know you've read about it, you probably don't use it very often.
So for me, medical marijuana is an interesting thing. I think it's a state rights issue. I have a federal license to prescribe narcotics, so I have no interest in being the first physician that gets in the middle of the litigation between the state of Arizona and the Drug Enforcement Administration. So, I hope patients understand me begging off on that particular circumstance. My feelings are, if you're a citizen of the state of Arizona, the Arizona's passed a law, that's your right as a citizen of the state of Arizona. I am not aware of any literature that shows that you're increased risk from having an adverse event on that, especially with concomitant narcotic management of pain, which is a big concern. So one of the big concerns is, say, if you're taking a benzodiazepine with your narcotic, of course, very high risk for an adverse event.
Yes.
And we cover those things. No alcohol consumption, for instance, on narcotic management of pain. But marijuana, I don't know that there's any issues.
Well,
in that regard.
I really wasn't trying to get you involved with it, and other than to say whether it was part of your armamentarium.
Right.
We're actually out of time.
Okay.
And a very interesting discussion. I really appreciate your thought process of functionality, which guides your approach to treatment. And I think that for our listeners' standpoint, to recognize how a physician views pain management is important, because maintaining your functionality is what it's all about. And we thank you for listening to us, and we thank Dr. Trujillo today. And stay tuned and stay healthy. We thank you.